I'd like to ask Liane Feldman to come speak now. Liane is Associate Professor of Surgery at McGill University in Montreal, and she's going to talk about strategies for effective integration of FLS into your skills program. Liane.
Thanks, Mike. Thanks, Mike and Dan, for inviting me to talk to you today, and good afternoon. Oh, yeah. Okay. So those are my disclosures. So the Fundamentals of Laparoscopic Surgery program, or FLS, is an educational program that was introduced by SAGES in 2004. And the goals of the program are to teach and to assess the cognitive knowledge and technical skills that are fundamental to the performance of basic laparoscopic surgery. Is anyone here not familiar with FLS? Okay, so just in summary, just quickly to summarize it, obviously there's a cognitive component that's a multimedia study guide, and now that's a web-based study guide. And there's the trainer box, which consists of 5 tasks, which I'll review for you. And then, importantly, there's the assessment component, which is a proctored exam that covers the cognitive knowledge and technical skills components. So it's just an example of the didactic component. It's very well done, lots of good images. And the trainer box consists of consists of a regular trainer box where you use your regular laparoscopic instruments. It has a camera attached to a monitor. 5 tasks: a transfer task, pattern cutting, endoloop placement, and 2 suturing with extracorporeal and intracorporeal knot. And each task has standardized metrics assessed by a proctor, and the metrics are based on rewarding efficiency and penalizing errors and coming up with a score, and a higher score is better. And both the cognitive and the manual skills assessments discriminate between groups with different levels of clinical laparoscopic experience, and that means there's evidence for the validity of those metrics. And the important political statement is that the FLS certification is mandated by the American Board of Surgery for all graduating surgical residents beginning this year, and that has huge implications. I think that's a really incredible statement. So basically that has pushed the agenda pretty dramatically in North America, in the United States particularly. And the first thing is if we want to integrate this into our curricula, obviously if this has forced the issue, we have to deal with this, and that's a good thing. So the first thing is how to get FLS. Right now that's available through an educational fund, industry educational fund, to support the introduction of FLS into accredited residency programs in Canada and the United States. And this includes both components, the didactic and manual skills component. It also supports the testing and access to testing. So if we want to understand some strategies for how to integrate FLS into our training, I guess the first question to ask is what are our objectives for that? And so we have 2 objectives for that. Obviously, the first objective is to prepare our residents to take the examination. But I will tell you in the next few minutes, and I will reassure you that it's not difficult to pass the examination. So that's the first thing to know. And I think Alan Okranik is going to present the data from the last 5 years of FLS testing, which will reassure people that with a little bit of exposure to the program, residents will pass the examination. So that's one aspect of our objectives, obviously. But I think, obviously, it would be a missed opportunity to get FLS and to start to understand what FLS does and not to use it really as a training component, an important training component, the goals of which are to use simulation to teach the fundamental technical skills required for laparoscopic surgery. I'm going to focus mostly on the technical component because the cognitive component is just basically like other cognitive tests for which we prepare by reviewing the information and taking a test. So I'm going to really focus on the technical component. And the second thing is to ensure retention of the skills so that the residents are prepared for clinical opportunities when they arise. And it may not be a week after they practiced, it may be 6 months later. And so that really, what I want to really discuss is information about developing expertise and what's the knowledge in developing expertise and what are some best practices or information about best practices for developing, for acquiring skills and acquiring technical skills. And it's not that different than acquiring skills in other domains like sports, for example. So in a variety of domains, like in sports, there's Alexander Ovechkin, hopefully he has a bad game tonight against Montreal, but probably not, or music or chess. There's a good deal of information that across these various domains, there are certain characteristics of practice that are associated with improved performance. And some of these characteristics are that the individual is given a task with a well-defined goal, that the individual is highly motivated to improve, that the individual is provided with feedback, and that the person has enough time an opportunity for repetition and to refine their performance. And this is what Erickson calls deliberate practice. So what I'd like to do in the next few minutes is to try to relate how these principles can apply to FLS or other kinds of skill training, but for FLS for today. So the first component that's important is to set a goal for training. That's very important. And I'd just like to differentiate between types of goals that we can set. We can set an experience-based goal or a proficiency-based goal. And proficiency-based goals are preferred because every surgeon experiences a learning curve, but we all learn at different rates. And an experience-based criteria like time or the number of repetitions, therefore, is not really appropriate to determine the completion of training because maybe I need 5 minutes and maybe somebody else needs 10 minutes and maybe someone else needs 1 minute. Really, the goal of training is to achieve a target level consistently, and experts not only achieve the target level, but they do it consistently, and there's very little variability between experts. So those are some of the important components. And the target should be what's the target? Should be representative of proficient population. And it shouldn't be too high so that people, they should be able to achieve it. It should be what's happening in the real world. So one program with training goals that I'd like to just walk through a little bit is what is available through the website, through the FLS program, through the SAGES website. So this is a curriculum that Matt Ritter and Danny Scott have published, and I think there's some very important components of that, and I just want to go through it. So the first thing is that the metrics, the training goal is derived from expert, and maybe this training goal is too hard, or maybe it isn't. You can set your own proficiency goals, but the importance is that it's set by an expert or by an experienced person. The second aspect is that these are metrics that are modified to allow for independent practice. Because as I mentioned, the standard FLS metrics require a proctor to score you, and then some math to come up with the score. So this way, those metrics, the scoring system is all published, and you can see how it's scored. And then, but what they've done is to instead set a time limit during which the goal is to complete the task with these allowable errors. And another important component is that they require some consistency. So it's not just that you hit it once and you're lucky and you stop. You have to hit it consistently. And the focus is on the tasks that also don't have as much consumable or disposable components to them. So the peg transfer task, there's a big focus on the peg transfer task as the building block for the other tasks. So that's one proficiency curriculum. Now, if you do this, you will pass FLS. Everybody passes FLS after this type of proficiency-based training. So even medical students. So in this is a study where there's 21 medical students. This is a line for the passing score for FLS. And you could see before that there's a lot of variability in performance. None of the subjects would pass FLS, which is probably good, medical students. And they went through the proficiency curriculum that I showed you. They practiced independently, so it was non-proctored practice. And they practiced each task in order to proficiency level. It's hard. They had to do peg transfer 60 times. And that's a characteristic of deliberate practice. It's not fun, a lot of it. And that's true across many domains. Practicing volleys at the net, playing for hours and hours at a time is not necessarily fun either, but that's how to get better at something. And after this curriculum, all of them passed FLS with flying colors. They're well above the score required to pass FLS. And you can see how the variability in performances also decreases. That's consistent with developing expertise. And this whole program took about 10 hours of practice. Now, why, okay. Now, I showed you that they train to a much higher level than is required to pass FLS. Why is that a principle that might be important? And it's called overtraining, and it has a benefit probably on retention. This is just, these are 16 medical students. They're doing the peg transfer task. They did it 10 times a week. They had 4 sessions, once a week. They did it 10 times at each session. And you could see that for these medical students, it only took about 6 times to pass FLS. So again, passing FLS is something that's attainable by our residents, obviously. But you can see that their performance doesn't plateau until at least 30 or maybe even 40 iterations. And what's important there for retention is that when they come back between week 1 and week 2, you see some degradation in their skill. Not back to baseline, obviously, but there's some degradation. But by the time they get out to 3 weeks, there's no longer this degradation. So there's a benefit of this kind of overtraining on retention. The next component of deliberate practice that's important is motivation. And as I mentioned, some of this is not obvious to residents that this is important. And it doesn't seem connected to what happens in the operating room. And it's important that we give them some kind of motivation. And it turns out that just setting proficiency targets also increases motivation. Besides the other good things that we talked about is having a training goal, it increases motivation. So in this nice study, it just was published in PGY1s. They got to access to the simulator in protected time. It was mandatory that they went to the simulation. Half of them were given proficiency targets and half weren't. That's all they did differently. And the people that were given the proficiency targets, they practiced a lot more. Look at the video trainer, 126 times versus 13 times repetitions in the video trainer. And this translated into that they made fewer errors during their first laparoscopic cholecystectomy. Other ways that we provide motivation is that we provide external motivation by making this mandatory. If you have voluntary access to your skill center and just tell people to practice, they don't. But if it's a mandatory component of their curriculum, like you would have a teaching conference and require, like Mike had a room full of residents there, probably because they have to go to teaching conference and they have to go to simulation as well. That helps get people involved. The third component of deliberate practice is some feedback. So one way that we provide feedback is by the metrics that we described, especially the modified metrics that give people a time limit to complete the task without errors. And then we have them, it's nice to keep a log so you can see their progress. But it is also important to have some expert feedback during the process. And you can call that coaching if you like sports metaphors. And expert feedback during some training session, not all of it. There has to be some independent practice too, but some expert feedback is important to demonstrate the steps of the task, to correct errors, and to provide tips and strategies. And it's also important for the residents to see that there's the culture that this is important, that the faculty is involved with this. But it's also useful if there's some non-surgical skills personnel to help with just to be more widely available. The fourth component is to allow time for practice and to allow enough time to practice, and also the way that the practice sessions are set up. So you can do massed practice where people come for half day or a full day simulation center course, and they do 5 hours or 6 hours of simulation, or distributed practice where they do an hour session every few weeks to months, and distributed practice is superior. It's harder to organize, but it's superior. It also avoids delay between the learning the skill in the lab and when you use it in the operating room. And again, it's another component that increases retention of the skill over time. The final component I want to discuss is that even after the people reach proficiency, it's a good idea to check in on them a few months later. There will be some degradation of skill, but then with a little bit of retraining, you can retrain to the proficiency levels fairly quickly, and then there's less degradation of the skill as you look further out in time. So these are some those are some of the components that I discussed for successful FLS proficiency training. And I just want to mention that this will help your residents perform better in the operating room. This is a study that is just published where our outcome was performance in the operating room for junior residents doing laparoscopic cholecystectomy. This is a global rating scale that we developed for the purposes of this study, and previously we validated it. And you can see that at baseline, all the residents are at about 12, which is where PGY 1 and 2s generally are. They were then randomized to either their usual on-the-job training or their usual on-the-job training plus FLS proficiency training, a little bit modified from the program that I showed you before. And after proficiency training, which took on average 7.5 hours of practice, on-the-job training, those residents improved in their operating room performance by about 15%, and that was significant from baseline, which is good. I mean, they are obviously learning something in the operating room. But the addition of FLS proficiency training, and remember that we're not teaching them to do a laparoscopic cholecystectomy, we're just teaching them basic psychomotor skills. But that group improved and these were blinded assessments. The assessors didn't know which group the residents were in. They improved their operating room performance by 54% in the same period of time. So now that's the ideal, what we know, that's the science, but what do we do in the real world? So where I work, we have a lot of great ingredients for success, and I'm going to tell you that we don't do all of them. We have a lot of ingredients. We have a fantastic simulation center. It is really beautiful. But unfortunately, it's not in the hospital. It's off-site. It's a few kilometers away, but it's not where we live. We have a coordinator for education for our skill center, but she's not part of our department. She's part of our MIS center. And obviously, we have a lot of motivated faculty. And we have protected teaching time. So every Wednesday from 1 to 5, our residents are expected at teaching conference. Except some of them, a lot of them, there's always something else that happens. But they are supposed to come to protected teaching time. So what are some of the challenges? We have 50 residents. We have 10 residents a year. There's a lot of variable interest in residents. Some are headed for vascular surgery, cardiac surgery, plastic surgery. They're going to be breast surgeons. And also, as they get more advanced, they not as interested in this type of thing. We can't, during our protected time, we have that massive time, but we can't proctor practice for 50 people at one time. We only have 6 FLS stations. We have a lot of residents. They're at different skills. And we can't formally assess them during that time because then we would just run out of time. That's all we would do. What about independent practice? How do people do the independent practice? Where do they do that? And when are they supposed to do that? If they don't have access, we have a skills lab at one of our hospitals, at the Montreal General. There's 3 FLS boxes there. And at the other sites, some of them have an FLS box somewhere. Maybe they have the equipment, maybe they don't. So there's some issues with that. And also cost issues, particularly with sutures. If you don't have people donating that can be very expensive. So what are we currently doing right now at our place? We do a course in July. Everybody comes, PGY 1 to 4, at the Simulation Center. We do a 5-hour course with the didactic material, as well as a proctored practice session where we have a lot of our faculty there demonstrating the tasks. There's 3 or 4 residents per station, and we have a few hours where we can demonstrate the task and do some proctored practice. We review the proficiency goals, and we give the PGY1s a logbook at that time and a CD with the task tutorials. And we do modified testing just by time for task 5, the intracorporeal suturing task, at the end of the session, so people get an idea of where they stand. We then ask the PGY1s to train during the summer where we don't have the didactic teaching. So they theoretically are free, not in the operating room from Wednesday afternoons, but they don't have the teaching conference. So that's the time where we would like the PGY1s to do proficiency training. And we know this is going to require an average of 7 hours, but the range is about 5 to 12 hours of training, and we'd like to do it over a few sessions, so it's a bit distributed. We have our MIS fellow and the coordinator schedule sessions with the PGY1s at one of our hospitals. We also give them keycard access to the lab at the General. And some information, at some sites there are FLS boxes if they know where to look. And then when not all of them reach proficiency, not all of them reach the high level of proficiency, but most of them participate in some practice sessions. It's better than nothing. If they do reach the FLS proficiency curriculum, we give them a certificate, and we recommend to our faculty to require this prior to beginning the laparoscopic cases, because we know from our own data that we're creating a pre-trained novice here, and that's what we want. But we don't, it's not mandated, but it's recommended. The other event that we do to provide sort of positive reinforcement as opposed to you must do this is we do a suture competition in April at the Simulation Center. Everyone's supposed to be there. It's supposed to be a fun event but we start with practice, proctored practice, and then we do a competition with, it's pretty lively. We have music, we have food. People, you know, they encourage each other, discourage each other, and we pick a winner, and the winner goes to the Canadian Surgery Forum in the fall. And we began a national suturing competition last year at our Canadian Surgery Forum, which was a lot of fun. And every program, we had 11 of 16 programs send residents to the competition, which was fun. And then when do we do FLS testing, formal FLS testing? We wait till PGY4 to do formal testing because I don't want people certified before then, because I want them to participate in my practice sessions so that I know that they're maintaining their skills. And we are lucky because we're a testing site, so we can, and then we just test them during the PGY4 year, and everybody passes. So just a little bit of a summary. The FLS program provides a uniform curriculum, which is good. It's also required by the American Board of Surgery, which forces the issue in a really important political way, I think. And this provides us the opportunity to use FLS for skills training. I've outlined the optimal approach based on the principles of deliberate practice, and we have tried to use these principles to inform our own curriculum, and this combined with our local realities basically guide effective integration of FLS into our training program. So I'd be happy to take any questions in the discussion period. Thanks.
Thank you, Dr. Feldman.